Hello everyone and welcome back. Sorry it took me so long to get in today. I couldn't authenticate the host for some reason or another, so I had some trouble getting in, so I apologize for the delay this morning. A couple of announcements before we get started. Your lab practicals are not graded, and they probably won't be graded for a couple of days. I'm going to try to get them knocked out as much as I can tomorrow. It typically takes me like a week to get through all of them. So your lab practicals, look to have those back by next Monday, and you might even get an email from me saying that they're done now. Whenever I finish grading an assessment, I always will send you an email announcement via Blackboard saying that, hey, grades have been posted. So once I get them graded and posted onto Blackboard, I will send you guys a message, and I will have all of that updated for you. Also, remember next week is our very first lecture exam. Yay! I know you're super excited. So the lecture exam is going to cover the first set of notes with the introductory information of A&P, the tissues in Chapter 4, as well as the integument in Chapter 5, and the bones, Chapter 6, and then this last little part that we're going to finish up today, articulation. So after our lecture today, this is the last bit of information that's going to be on this first exam. Next week on Monday, I am going to start muscles. So I'll start the skeletal muscle system, but that's not going to be on this exam. To help you prepare for this exam, you have learning objectives that are already posted. So I'm going to go ahead and share my desktop with you so that you can see exactly what I'm talking about. Okay, and let's move this over here. So if you go into your lecture lab content folder and you go to expected learning outcome or learning objectives, and then you click on this first one, learning objectives for exam 1, you will see the following, and it even says which portions, which chapters it's coming from. So these are your learning objectives, and this is the best thing that I can provide for you to a study guide. If you know these objectives, you're in a really good position. And for example, if it says know the different types of cells in a bone tissue and their function, osteocyte, matured bone cell, that would be a good starting place to say an osteocyte is a mature bone cell. But what I would do is I would have all the information that we talked about for an osteocyte. Osteocyte is a mature bone cell. Osteocytes are found in both the osteons, which is a unit of compact bone, as well as in the trabeculae, which are like the lattice words or the struts of spongy bone. The osteocytes have calcium deposits beside them. They have cytoplasmic extensions called cananiculi that allow for the osteocytes to communicate with other cells. So do you see how more involved the second description of an osteocyte is compared to the first description? The first description is absolutely true. It is a mature bone cell, but it's not really telling the whole story. So as you go through these learning objectives, because I take your exams right from your notes, which come directly from your book, if you give a more expanded definition or more expanded response to these different learning objectives, you'll be in a much better position when you take your exam. The exam will consist of 40 multiple choice questions. You will have 5 short fill-in-the-blank questions, so 40 multiple choice, so worth 2 points apiece. 5 fill-in-the-blank, they're also worth 2 points apiece. Good candidates for fill-in-the-blank questions would be definitions. So blank is the study of structures of the body, anatomy. So anything that's a definition are always really good for fill in the blank because it's usually a very clear answer to what that question is. So you'll have 40 multiple choice, 5 fill in the blank, and then I will give you an option of 4 to 5 short answer questions, and you only need to pick 2 of those short answer questions for me. So out of those 4 or 5 questions there, one is definitely going to be discussing the process of endochondral or intermembranous ossification. Remember, anything that I said is a process. Those are always really good questions for short answer questions. Also in the integument system, we talked about repairing the integument. That's a really good option for a short answer question as well. And there are many others that I could put in there, but anything that is a process, make sure you know that. So of those 4 or 5 short answer question options I give you on your exam, you only need to answer 2, and they're worth they're each worth 5 points apiece. So for many of you all, you're going to be taking your exam with me on Thursday in the rooms that are listed on that email that I sent you on Blackboard. And I'll send a reminder email again this afternoon. For some of you, you'll be taking it with me on Wednesday. On Wednesday evening, 5 o'clock or a couple of minutes after 5 o'clock, I know some of you guys are coming from work and you're not going to make it exactly at 5, but on that Wednesday evening, we're just going to meet in our lab room. So we'll meet in our lab room for you to take, which is SW104, and you'll take your exam then. I think that's all of my housekeeping sort of stuff. On Monday, we will still have lab, and we're going to start going over Unit 2. So make sure you look at that in your lab book. That's where we begin to look at the bones and muscles of the appendicular skeleton, or the lower and the upper extremities. So make sure that you start to review that for your lab on Monday. We'll still have a full lab on Monday, even though it's an exam week. And remember, you're taking your exam either on Wednesday or on Thursday, or if you've made other arrangements with me. So I think that's all my housekeeping stuff. Don't think I forgot anything. If so, I'll put it in an announcement. All right, so the last little bit of our notes here are going to come from Chapter 9. I'm only taking, so if you're reviewing and use your textbook, only read the portion in your textbook that covers articulations, because that's all I really want to kind of take out of Chapter 9 here. The way that we define an articulation is any body movement that happens at the joint. So any point where two bones connect with one another, we consider that an articulation. There are all different types of joint structures, which you're probably very intimately familiar with. You're acquainted with that. That's your shoulder joints, your knee joints, your elbow joints, your hip joints. They're not all exactly the same. So there are different types of ranges of motion that can be attributed to a joint. How the direction and the distance of that movement is going to be determined by the entities or the particles, the types of muscles and ligaments and bones that are in that particular joint. Very important thing that I want you to remember and to understand is that joint strength is going to decrease as mobility increases. So the more flexible, the more mobile a joint is, the less strength that it can confer. So one of the examples of the joints that we're going to talk about are between your left and your right pubic bone. That joint there doesn't really have as much mobility as, let's say, your shoulder joint. Even though it doesn't have as much mobility, it's extremely strong, which is a good thing because it keeps your left and your right pubic bones kind of hanging out there together. Any joint that has a lot of mobility, like your shoulder joints, they're just not super strong. And you see a lot of people that are athletic pitchers, anyone that does any repetitive motion with their arms, volleyball players. My daughter is double jointed. She's 14 years old, and she can clasp her hands in like a prayer position in front of her, and then she can take her arms and go all the way around her head and past her legs. So she can go make a full 360-degree circle. Because she has a lot of mobility in that joint naturally, she's kind of prone to injuries in volleyball with her serve. So she's got a lot of movement in that joint, but she doesn't have nearly as much strength. She's even dislocated her shoulder, and she's able to kind of, and it's really not a full dislocation, it's more what we call a subluxation. She's able to pop that dislocated shoulder back into place. So just a really good example of how she's got a ton of flexibility, but there isn't a whole lot of strength conferred in that joint. So there are two ways that we can classify joints. In much the same way, there were a couple of ways that we could classify bones. But the two ways that we classify joints are that they can be functional or they can be structural. Functional joints are going to be based on the range of motion. How much movement can we have with that joint? And that's really the way that we're going to classify joints for your exam. And in this course, we're going to talk about the functional classifications. There's also a way that we can classify joints based on the types of structures that we find there. So if we look at the anatomical organization of the joint, what kind of muscles we find in this area, what kind of ligaments and tendons, that's another way that we can classify them. What we're going to spend a good chunk of our time on is talking about the three different functional classifications of joints. So the three functional classes of joints are synarthrosis, amphiarthrosis, and diarthrotic joints. synarthrotic joints are what we consider immovable joints. And what we know about joint strength and joint mobility is that as one increases, the other decreases. If synarthrotic joints are immovable joints, then already in your mind you should be visualizing, okay, these must be very strong joints. There's very little, if any, movement at all. Sometimes the joints can fuse over time. Fibrous and cartilaginous connections are good examples of synarthrotic joints. So from your sternum to some of your ribs, you have some cartilage that connects the rib to the sternum. That would be a good example of a synarthrotic joint. The sutures that are in your skull are also examples of synarthrotic joints, where there's still two bones meeting together, so those parietal bones, those flat bones that when you say ay, 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 and you grab the side of your head in frustration, you're usually grabbing your parietal bones there. They touch one another right there in the center. That joint, it's still considered a joint because it's still a point where two bones meet one another, is an example of a synarthrotic joint. And we kind of want that to be a non-movable joint. We kind of want it to fuse over time because it's housing a very important organ of your brain. Amphiarthrotic joints are slightly movable, so there's a little bit of movement that we can get there. You also have fibrous or cartilaginous connections, but because of the other structures that are available, that joint has more mobility than, let's say, the sutures of your skull or those little cracks on your skull where those bones touch one another. Great example of that is your pubic symphysis, or when your left and your right pubic bone, that point where they connect with one another, articulate with one another. And then the highly movable or freely movable joint is your diarthrotic joint. They have a lot of movement, and another name, what we usually call diarthrotic joints, are synovial joints. And we can further divide different types of diarthrotic joints based on the type of motion that we can have. So your shoulder would be a good example of that. Your knee, your ankles, your wrists, those are very highly movable joints or articulations between those bones. And your shoulder, your knees, your fingers, your wrists, your ankles, they each have their own different type of synovial joints, because they can be further subdivided by what type of motion, protonation, and whatnot that they will allow. Now for the structural classification, remember this is where we just talk about those anatomical features, where it can be a bony joint, where two bones fuse together. Good example of that would be that synarthrotic joint of your skull. It can be fibrous joints where we have a fibrous capsule that helps to make up that joint and confer some strength for it. And cartilaginous, both fibrous and cartilaginous, pubic symphysis would be an example of that, because there's cartilage or some sort of fiber that's helping to creates that articulation, that point of connection between the two bones. And then we've already talked about how synovial joints, their term that we used for that was a diarthrotic joint, or diarthrosis. So going on, remember we're going to talk mostly about those functional classifications. So just a little bit more detail on synarthroses. Synarthroses are very, very strong, but because they're very strong, once again, they don't really have a whole lot of motility to them or mobility to them. At synarthrotic joints, the edges of the bones can touch each other, or sometimes they even interlock. Great example of synarthrotic joints are the sutures that make up your skull, so where your left parietal bone and your right parietal bone meet one another, and how it meets with your frontal bone in the front of the skull and your occipital bone in the back of the skull. All of those are great examples of synarthrotic joints, and we call those connection sutures. So those are all good immovable joints, and those sutures, after over time, after you're no longer an infant, and I think about the time you're like 5 or 6 years old, you no longer have a soft spot. And yes, some 5-year-olds still have a soft spot, if you will, because those bones haven't fully fused yet. So they're not completely fused at birth, because we need to have some ability to expand for the brain to grow, and we also need to have some flexibility for when the child comes through the birth canal, which is kind of a tight spot. It's not like there's a whole lot of room there. Gomphoses are joints where your teeth bind into your mandible or your maxilla, so the bones that make up your jaw, your upper jaw and your lower jaw. Gomphoses are where the teeth will actually bind to those bones. Synchondroses are joints where we have the sternum connecting to the ribs, and there's some cartilage there that connects them. So synchondroses means that these are immovable joints with a connection using cartilage. So in this word we see con, and you probably think of a chondrocyte, which is a cartilage cell. So synchondroses are joints that are immovable, and they have cartilage as part of the joint structure. And stenosis are joints that just don't move. They fuse. These are joints that are fused completely, and there's absolutely no flexibility or movement with them at all. So suture joints we've kind of talked about already. Sutures are only found in the skull. They're bound by dense fibrous connective tissue that helps to, there aren't any really ligaments, if you will, they're not huge ligaments that connect these joints together. They're more of a dense fibrous connective tissue that keeps them hooked together. Gamphosis, remember those are going to bind the teeth into the socket. That's another type of synarthrotic joint. Synchondroses, cartilage between two bones. We've already talked about the vertebrosternal ribs and the sternum, connection between the sternum and the ribs, and then also the connection between the ribs and the vertebral column. I didn't go all the way in the back, but that's also considered a synchondrosis joint. One we haven't talked about is that epiphyseal cartilage, that epiphyseal line, that's considered a type of synchondrosis as well. That little line of hyaline cartilage that is left over so that the bone can continue to grow longer. So that epiphyseal cartilage is also considered a synchondrosis. And then stenosis, just they don't move at all. Bones fuse, so your forehead as it connects to the left and the right parietal bone. So when you grab your forehead, if you put the palm of your hand on your forehead and then just tap your fingers onto your head, where you're tapping your fingers is probably hitting your left and your right parietal bone. So that suture, or that joint that connects the forehead bone with the next two large bones of your skull, that's considered a joint that's fused, and that's where that fusing has happened after you no longer have your soft spot. So that completely fuses over there. And then that epiphyseal line of your long bone, and once you're no longer growing, once we've used all that cartilage up, and that's also considered a stenosis. Amphiarthrotic joints are much more movable than synarthrotic joints because they have more mobility to them. They are not as strong as synarthrotic joints. However, they are stronger than diarthrotic joints or synovial joints. So they fit right there in the middle, hence the name amphi. So you get the best of both worlds. Two different types of amphiarthrosis. Syndesmosis, which are the bones connected by ligaments, so where we have a bone connected to another bone via a ligament, is semidesmosis. And then symphysis, like your pubic symphysis bones, where bones are separated by a very thick fibrocartilage. So the bone between your left and your right pelvic bones, it's not really just one bone. There are actually two of them together, and then it's your fibrous cartilage, the pubic symphysis, that articulates those bones with one another. So there is some mobility. So think about how your legs walk, and if you're able to do the splits, you do have some mobility. There is a lot of strength there. But if you play with Barbies, like I play with Barbies sometimes, I would make one leg stay down and the other one just completely go in a 360-degree circle. Yeah, you don't work like that. So it doesn't allow that much flexibility. So you can't just take one leg and rotate it 360 degrees, and even the most flexible Cirque du Soleil performers and gymnasts aren't able to do that because you have that pubic symphysis there. You don't have that much mobility, but you do have quite a bit. And you probably think I was like a torturing person. No, I just like to see how things worked. So my mom would buy me dolls, and I would always take them apart because I wanted to see how they worked. And I try to put them back together, or try to put them on top of trucks, or anything else. I really wasn't a weird kid. I just was inquisitive. Anywho, synovial joints are last joint. These are highly movable joints. It's diarthrosis. We find them at the ends of our long bones, so shoulders, knees, elbows, wrists, all of those are considered synovial joints. Synovial joints have actual articular capsules, and they're lined with the synovial membrane. So aspects of the synovial joints, or components of them, are their articular cartilages, and these articular cartilages are responsible for keeping the bones from having too much friction and rubbing directly against one another. Also, to prevent friction, we have synovial fluid. So the whole job of that synovial fluid is just to reduce the amount of friction that's in there, because there's a lot of movement that happens with these joints. And not only do we have a lot of movement, we have a lot of components that are at work. There are lots of things, lots of bones and muscles and fat and cartilages that are in this area. So they're all going to, and it's kind of a tight spot, so they're going to always be rubbing against one another. So having the synovial fluid helps to bathe everything in the joint with a lubricating agent, so it prevents friction. Synovial fluid is made out of proteoglycans that are secreted by the fibroblast in the joint itself. Jobs of synovial fluid are for lubrication, as we've already discussed. They also help to distribute nutrients. So any nutrients, oxygen, or whatever is coming into the joint, it all flows through the synovial fluid, and then it acts as a bit of a shock absorber, especially in a joint such as your knee, where your meniscus of your knee can actually absorb some of that synovial fluid, and as soon as you put pressure on that meniscus, it'll release an additional amount of that, and it acts as a shock absorber. Other structures we find in synovial joints, obviously we have cartilages, which we talked about, preventing bones from touching one another, and they also help to cushion them. So if we think of your knee as an example of a synovial joint, the meniscus is an articular disc that helps to cushion that joint. You also have fat pads that will surround it, so right above the joint capsule itself, so the business of the joint, you'll have fat that surrounds it, and it helps to protect the cartilage. You also have ligaments that help to support and further strengthen the joint. And remember, ligaments connect bone to bone, and tendons connect muscle to bone. So when we go into lab on Monday, we're going to look at an example of a knee joint, and we're going to talk about the quadricep tendon, which connects the quadricep muscle to the patella, and then we're going to talk about the patellar ligament, which connects the patella to the tibia. So it's a ligament on the bottom and a tendon up top, and whether we designate something as a tendon or a ligament depends on whether it's connecting bone to bone, patella, knee bone to tibia, knee bone, or patella, knee bone to muscle, or the quadricep muscle has the tendon on there. Injuries to your ligament or a sprain is when some of those collagen fibers actually are pulled or torn. If you completely tear a ligament, it's pretty difficult to do. You can only have that surgically repaired. And there are many ligaments in the knee. We just talked about one, the patellar ligament, but you have your ACL, which I'm sure you guys have all heard of, your anterior cruciate ligament, and your PCL, which doesn't get nearly as much discussion because it's the one that hangs out in the back, your posterior cruciate ligament, that if you completely tear that, you have to have surgery. One of the surgeries that they can do now is that they will actually take ligaments or tendons from other parts of your body, and they will drill through your tibia and then attach it with screws, a brand new ACL. And RG3, Robert Griffin III, who's I don't know where he's quarterbacking now, but he used to be the quarterback for the Washington Redskins. And I don't even know if they're still called the Redskins, because I know that was like culturally insensitive. Anywho, when he played for Washington, that was the surgery that he had to repair his ACL. Tendons are also another accessory structure. They, just like ligaments, help with joint support. Remember, tendons attach muscle to bone, ligaments attach bone to bone, and then bursae are just little pockets of synovial fluid, and they're cushions in areas where tendons or ligaments can rub, so they'll release the synovial fluid to help keep this area nice and lubricated and reduces friction. So things that help to stabilize synovial joints and prevent injury is that one thing that synovial joints will do is, because of the components that are in there, they somewhat limit the range of motion. For most people, for my daughter, it doesn't happen like that. Her range of motion is much greater than what it should be in her shoulder joints. So that's why she has some injuries just from serving sometime. She can, from overhand serving, she can have issues with that joint. So the collagen fibers in the joint capsules and those ligaments and those tendons, they only allow the joint to be so flexible, to only have so much movement. The articulating surfaces in the meniscus, other bones, muscles, fat, tendons, all of those accessory structures that we talked about in the previous slide, they're all entities designed to give the joint some flexibility, but also to give it some support. So to give it more than anything, to give it some support and prevent the joint from repeated injuries because the range of motion has been somewhat limited. So what we're looking at now is a sagittal section of a very simplistic synovial joint of your knee. And what we're looking at is if we were to take your knee and we were to cut it in a long fashion. So you're not looking at it from the front, you're not looking from the back, you're looking at it from the side if we cut it open. This top bone here would be your femur bone. This line would be your epiphyseal line, so this is where your growth plate was, your growth cartilage. And this bone down here would be your tibia bone. At the ends of the bone, they've kind of been cleaned up a lot. There are a lot of some ligaments missing, there's some muscle missing, but we're just looking at a very basic synovial joint. So at the end, we have this articular cartilage, the hyaline cartilage, that keeps these bones from rubbing against one another. This whole area outlined in pink, that's the joint cavity, and this is where you would find synovial fluid. Your fibrous joint capsule would be this area here, and then we even are looking at the periosteum, or the covering of the bone, that spongy bone that's in your epiphysis, or the knobby parts of your bone, and your medullary cavity. Now on this picture of it, we're still looking at a sagittal section of the knee. We took your knee and we cut it long. We didn't cut it horizontal, we cut it longitudinally, we cut it the long way, cut it vertical. We still see our femur and our tibia, we still see the articulating cartilages, but this time we're able to see additional accessories of the synovial joint, including the meniscus of your knee. We still have our synovial membrane that was outlined in pink there, but these little green type structures, your bursae, that are filled with synovial fluid. Aha, here we have that quadricep tendon that I told you all about. Notice it connects the quadricep muscle to the patella, or the knee bone, so we call it a tendon. However, when we connect the patella to the tibia, that structure right there, it's called the patellar ligament. So we have that in this area. We also have a lot of fat around here. So all of this fat helps to protect and cushion. And even with all of the stuff that we're seeing in this joint, we're still missing your ACL and your PCL. And it's probably because of the way that, we made this sagittal cut here. So these are just a lot of the important features of a synovial joint. And in fact, many of these structures you're going to become very familiar with in our next upcoming labs. Our next lab practical isn't until October 12th. So we've got quite a bit of time, in fact 3 weeks, to learn all of those muscles and bones of the upper and the lower extremities. And these are some of those muscles, bones and muscles and structures that you will be learning. So some injuries that typically happen with synovial joints, notice how we didn't really discuss injuries that would happen with synarthrotic joints or amphiarthrotic joints. Not that they can't happen, it's just that they're not nearly as common as synovial joint injuries because they're much more flexible. So remember, where we have more flexibility, we don't have nearly as much strength. So a dislocation or a luxation is when the articulating surfaces of two bones are pushed out of position. For a full dislocation, it means they have to be completely pushed out of position. And for these full dislocations, that usually involves some damage to the articular cartilage that covers the bones. That cartilage is missing, or there are parts of it that are missing. Ligaments are torn or really sprained, pulled, or the joint capsule is compromised. So a lot of times when we use the term dislocation, it's not really an accurate use of the term for the injury. What most people have, like my daughter that I talked about, is a subluxation, where it's just kind of partially dislocated. So those bones in her shoulder, they're just out of alignment with one another, because she can take her shoulder and like pop it back into place. She can take it out of joint and then she can pop it back into joint, and it's not really a big thing for her. I ask her not to do that because it creeps me out personally. So that's really more of a subluxation, and a lot of people have a subluxation. For a full dislocation, usually there has to be some medical attention sought for that, and it a lot of times will involve repair of the structures, those accessory structures that are in the joint. All right, so that is where we're going to end for today. Remember, this lecture is your last lecture for your Unit 1, or your very first lecture exam. There's no homework that you'll need to complete and turn in. We don't have a quiz on Monday. Monday's just going to be a good old-fashioned regular lab day. And you'll take your test on Wednesday, Thursday, or at another time designated by me or that we've kind of set up together. Make sure you go over your learning objectives, and as we said for your lab practical, relax, relate, release. It's not going to be bad. It'll be a good thing. All right, questions, comments, or concerns? So it's been kind of a short one today because I don't want to start anything new. I want to let all of this digest. If not, then I will see you all on Monday. Have a fantastic weekend. I hear it's going to be warm but sunny, and get some good studying in. All right? See you soon. Bye.